So if you're just joining this is a pharmacology lecture. It's going to be chapter 13. So again, medications, again, manage life threats, make quality of life improved, substantially take a lot of the symptoms and a lot of the problems away from people. It's not without, and the big thing we're going to talk about a lot is it's not without consequences. There's usually some type of side effect. The typical commercial that you see on TV, there's, it does this awesome thing, and there's 43 other things that are going to completely wreck your life as a side effect. So we got to be kind of careful about that. So as far as us giving medications, there are some life-threatening consequences. If we give the wrong medication, if we give the wrong dose or if we give it to them the wrong way, like the wrong route of access to the body, and we'll talk about some of that stuff, it can absolutely be a life threat. So pharmacology is a very, very important definition for you guys to understand. So pharmacology is exactly what it says here, a specific study of how various substances interact with or alter the function of a living organism. So basically, it's a medicine that we take, and the effects, desired or other or not desired, that it physically has on us. And that's pretty much what we're going to be going through today. So some of the historical stuff, we've been using medications for a long time, ever since they figured out that if you rub certain juju leaves on something, you can heal better. Like, this is caveman stuff. So this is long time ago. They decided that, hey, there's these synthetic things or these naturally occurring things that if you do it the right way, or you give it the right way, or you ingest it the right way, that somehow you can magically be fixed. So a lot of it did come from plant animal base. And then, of course, there's some formal stuff that happened along the way. So for us, once we figure out something works, so for example, this COVID vaccine or set of COVID vaccines that they keep working on, it's not just a magic thing. It doesn't just happen. They need to make sure that Pablo's not just making it in a bathtub somewhere in Cuba. It has to be a legitimate medicine that has legitimate side effects that have been tested, very, very, very specific. So that's very, very specific testing. They have to do blind studies and double blind studies, and they have to go through all the clinical trials just to make sure that it's actually something that's truly okay for us to go and administer on a regular basis. The other problem that they don't normally think about is that this has long-term consequences. So if you take a medicine every single day for your entire life, today I might feel kind of funny. This week, once it builds up in my system, I might feel kind of odd. But 30 years from now, what is it doing to me? What is it doing to my liver and my kidneys? So things like that. And again, that's more the chronic stuff. On the pharmacology side, for us as medics, everything we do is a relatively short term. We have one medication that we can give. It's called amiodarone. It's for cardiac dysrhythmia. That medication can stay in the body for like 45 days and kind of wreak havoc. But that's 45 days is about the lifespan for that medication. And that's one of the longest ones that we can mess with. And actually, there's some other ones. So we do have a drug regulation system. This goes into the U.S. or I'm sorry, the FDA. So the FDA is the main body that governs safety and use and indications and contraindications and all of that. And there was back in early 1900s, 1906, there was a whole thing that went through prohibiting mislabeling of medications. They would say, they would put these leaves in a jar and call it something very specific for medicinal purposes, and it wasn't. So they had to come up with an actual legal act to try to make sure that that this stuff is somewhat usable. And then, of course, you get into the world of opiates and cocaine and all of the other stuff that they found out they could grow on their own. So of course that triggered a response that they needed to put some kind of regulatory body in there. And a lot of it comes down to money. So they wanted the money from it. They wanted tax money. They wanted kickback. And then they realized that, well, wait a minute, this isn't healthy. It's not safe. There's absolutely zero medicinal value to those particular types of medications. So early on, there was a Harrison Narcotic Act. It was an act that basically prohibited that it basically put a restriction on the use of those without the actual guidance of a doctor. So again, there's some history that goes back through here. This is what applies to us, though. So new medication takes years, unless it's COVID, and then it takes a couple months. It's kind of amazing how that works. The big thing, the big term on this page is off-label. Off-label is a very, very, very important thing for us to understand. Glucagon. So we have medication. Glucagon is basically a smooth muscle relaxant, and it also forces, and we learned in the past that it forces the body to release stored glucose and glycogen. We use it for diabetics. If you make a run on a patient that has a food embolus, so they took a big piece of steak, it's not in the trachea, so it's not an airway obstruction, but it went down the esophagus, but it got stuck in the esophagus prior to the stomach. That food embolus is super, super painful. It's very, very uncomfortable. If the embolus is big enough, it can actually restrict blood flow going down the esophagus. So an off-label use for glucagon is for a food embolus. Now, again, a lot of this is protocol driven, but basically they've decided that because glucagon works the way it works, it is a smooth muscle relaxant. So it will relax the inside muscles of the esophagus and allow that food to pass. That is not an FDA approved use for glucagon, but it's one that we use. It's something that we do. And that's, again, it's protocol driven, but it's not necessarily approved by the manufacturer. So that is technically an off-label use that's not approved by the FDA. So just kind of keep that in mind, that we still do some of that stuff, and a lot of that is dictated by the doctors. So with that said, a doctor in the emergency room has the ability to kind of circumvent a lot of this stuff. So atropine. Atropine is a medication that allows our heart to not restrict itself, and it allows it to beat faster. And again, we'll get into all of that stuff. I don't necessarily need you to remember that, but atropine will also help with certain toxic overdoses. If somebody has some type of ingestion of like an organophosphate or some type of fertilizer or something, we can actually use this atropine off-label for the treatment of that. So just know that there's some things out there that the protocols are going to have us do that aren't necessarily something that they initially wanted this medication to be used for. This is 100% important for you to know. You have to know this. The classification of medication. So class 1 or schedule 1, you're going to see the term schedule. These are highly abusive, they are highly addictive, and they are absolutely of zero medical purpose. So you have to know that. Moving down to class 2. So class 1 is like the heroin and cocaine and all the other stuff that we obviously are not going to be scheduling or prescribing or giving or any of that stuff. So again, high abuse potential. Moving down to all the way from 1 to 5. 5 is the least. The least. It's a low potential for abuse. Very, very common. It's a common medication that we're going to be able to use. So this is like your. This is some of the stuff that they send you home for, like some codeine, like cough syrup with codeine, stuff like that. It's not stuff that we're going to mess too much with. But somewhere in between there, so fentanyl, we absolutely do use fentanyl. It says cocaine here. We're not going to be doing a whole lot with cocaine. That's certainly, there's some medicinal value to that, and we'll talk about that some other day. But the big ones on here we're going to use is fentanyl. Because it's a Schedule II, it's heavily regulated by the FDA. So anytime I give fentanyl, or anytime you guys give fentanyl or morphine or anything that's pain or narcotic-based pain medication, we're going to have to do some pretty significant paperwork to get that done. Moving down through, you can kind of read through, but just know, just kind of have a general idea of what the description is. So it goes from very high abuse with no medical value whatsoever, all the way down to relatively safe, where there's a low potential for abuse with a high usage rating for medical purposes. So again, there's 5 major schedules or 5 major classifications of medications. By medications, by the way, I mean controlled medications. So like Tylenol without codeine, just regular over-the-counter stuff, that does not fall into this. This is the prescribed controlled substances. And this is all part of a Controlled Substances Act that happened in 1970. Hopefully that makes sense. So where do we get this stuff? So we get it from plants and animals, and we make it, and some things we make part of it and we add it to something that's naturally occurring. 100% of the time something is done in a lab. And if it's not done in a lab, then it's either something holistic or herbs, or you'll hear a whole lot about oils, essential oils, and stuff like that. And we'll talk a little bit about that stuff. But basically, the pharmaceutical company that processes it in the lab study, they make sure that there's a concentration of purity preservatives. These are the big key things that they have to control, these 4 things. They have to make sure that the dose that you're giving is exactly what the dose on the label says. They have to make sure there's no floaties in there. Nobody wants to give something with byproduct or dust or debris or something in it. So the purity is up to the pharmaceutical company to take care of. Preservatives, that pretty much allows it to have a good shelf life. When you pull out a vial of medicine, some of them are clear and see-through, and some of them are not. So, Versed, there's a lot of times the medication we give for seizures and sedation, the vials are brown. Those are usually brown because the preservatives are not as strong or as potent. So it's sensitive to sunlight. It's sensitive to UV light. That's also why a lot of times when you get like an antibiotic from the doctor, it's in like an orange hued vial. Specifically like the prescribed Robitussin or the prescribed cough medicine. It's in like an orange bottle. And again, that all has to do with UV sensitivity. So that all relates back to the preservatives. Dye. So what makes a liquid medication blue or red or whatever is usually some type of dye. And it's not uncommon for your patients to have an allergy to one of the dyes that are used inside the medications. Fortunately for us, a majority of the meds that we use, by majority I mean all of them are clear. So with one exception, but that's they're clear. So there's not going to be any kind of dyes. So we don't have to worry necessarily about that. So the pharmaceutical company then has to provide a lot number, which is basically this is the group that this particular vial of medication was manufactured with. So basically, if one of the users contaminated that particular lot or that particular set of vials, they can track down where those vials went and get rid of them. And also they're required to have an expiration date. A fun fact in all of this is that everything you use, all the way down to the 4x4s that are on your ambulance, everything has an expiration date. What we're finding is during a time of crisis or an emergency, that seems to be more of a suggested manufacturer expiration date. An example of that is like epinephrine. When epinephrine, when that expires, the FDA has said, well, yeah, it's a suggested thing. We're actually out of it right now. It's back ordered nationally, so you guys can go ahead and use that for an additional year on top of the year from the expiration date. And all of us on the user end just shake our head because really that just shows you where they monetize this. If you're telling me that this medication is just as good 2 years from now, then why did you put a 1-year expiration date on it? Well, it's because you have to buy more. And, again, that's just a general suggestion. But likewise, if you get in your medicine cabinet 2 years from now and you say, oh, this is that cough medicine from back when, and it expired in 2017, it doesn't necessarily mean that medicine won't work. It just means that the active ingredient that makes the medicine work may not be quite as strong. It might not be quite as potent. So that's just kind of what happens when the expiration date comes and goes. So here's the kind of forms that these pharmaceutical companies are putting in. This is very important to understand. So capsule is basically it's usually a powdered compressed tablet. This is, again, we know what these are. This is typically like your basic Tylenol. When you pull those Tylenols out. Does somebody have a question?
Yeah. So basically the expiration dates on medicine, is that just the half-life of that medication?
So the expiration date is, so basically the manufacturer says, hey, this medicine may not potentially be 100% effective after this particular date. And again, that has to do with the active ingredient losing its potential power. So narcotics, I guess that's kind of a bad example. Ativan and some of the other sedatives, what makes that work doesn't necessarily work forever. It's not a living thing, but basically the longer that you go without using it and it's sitting on a shelf, it settles and it absolutely loses its action potential. And we'll talk a little bit more about that, but that's a really good question. So capsules are the powdered, pressed together things. A tablet in general can be usually they're covered with some type of some kind of gelatin of some kind. So if you think about your maybe the ibuprofen tablets that they used to put out that were like a red or a brown color, if you know what I'm talking about, a lot of those they had some kind of coating on them. That's definitely one of these here. A powder, very, very seldom do we use a powder with a couple examples, one of which is the glucagon. Glucagon is not stored as a liquid. The vials, there's usually 2 of them. So glucagon, again, we use it for blood or for diabetes and for blood sugar correction. There's a powder, so and the second vial has just 1 ml or 1 milliliter of saline in it. So you got to take a syringe, you got to draw out the saline, constitute this. So you spray the saline, you squirt the saline into the powder vial, and then you shake it up. Solumedrol is another one. It's a steroid that we give. And all of these are medications that we're going to get into today and moving forward. But these 2 powder medications, they have to be reconstituted before we can give it to them. So we have to introduce some type of mixing fluid or agent. And usually we just use saline, and that's what comes with it. Let me go back. Sorry, let me skip forward. So droplet, we don't do a whole lot with droplets. We don't usually use any of the nasal sprays. And if you are one that uses Afrin, I can give you a million reasons why that's probably not the best thing. So especially if you're using it regularly, we need to chat, because that's no good. But kind of keep in mind, there are some droplets, and we do use the neosynephrine. It's just a nasal spray that we squirt up into the nose. What you guys are going to find out moving forward is that there is some medication that we can give multiple different ways. So one specific example of that is fentanyl. Fentanyl, I can put it in a needle with a syringe. I can stick it in their shoulder or their, wherever, and I can give it in their deltoid and administer it intramuscular. I can also put it in IV and give it intravenously. I can also put a MAD device on it, like the Narcan MAD devices, and I can squirt it in the nose. So that can be droplet administered, just the same as it can any other way. Parenteral, sorry. This is the easiest way, and you will need to remember that particular phrase. The easiest way to think about that is with little kids, a parent has to physically give them a medication to swallow for it to physically go into the body in any way, shape, or form. So somebody has to physically inject that or physically put that in. So, a parent, if you look at the word, a parent has to physically administer that. And again, usually that's an injection or a shot. So that can be something like epi, that can be fentanyl, that can be, to a certain extent, that can be like insulin and some other things that we'll give. But understand that particular term is a direct injection. Skin preparation, we don't use any of that stuff. We don't have nitro patches. We don't do any of that stuff, but just, these pharmaceutical companies, again, these are the different ways that they have to prepare this. Fentanyl pain patches and stuff like that. You guys will see that on a pretty regular basis. You get a cancer patient that's altered, and you get dispatched just for an altered patient. If you get there, there's times where you'll find there's 2 or 3 pain patches on. Either they did it intentionally or they didn't. But that's obviously through the skin, they've essentially overdosed themselves. Suppository, you'll probably need to know this later, but a suppository is a wax-like material. They stick it in the rectum or any other body cavity. The one time that you're going to see this more often than not is going to be diastat for seizures. So if there's a seizure disorder patient and they go home, they'll send them home with some type of rectal Valium. A lot of times that can be a spray or a self. It's like an auto injector, but there are the wax-like dissolvable tablets that actually go up in the rectum. So this is really, really good for kids. Specifically kids that can't take a medication. This is really, really important for Phenergan or promethazine, this term that you see here. This is another medication that we're going to get into later, but it's an antiemetic. It prevents vomiting. If you're vomiting, I can't give you a pill to swallow. That's counterproductive. And if I don't have an IV or IV access, there's really no other way to give it. So we don't do this in the field, but there are prescriptions to go home with a Phenergan suppository. And again, it's just if you're vomiting, you can't take it like other people do. We all know what liquid is, and we all know what inhalers and aerosolized medications are. All right, some more important stuff. And again, I'm trying to highlight some of the important stuff that you absolutely need. So there are different names of different medications. The manufacturer themselves can create the chemical name, and that particular chemical name is important for development. They're usually really, really long and hyphenated and kind of hard to pronounce. We rarely see that. We don't usually see the chemicals that make the medication work. What we usually see is more of the non-proprietary generic term. So, and we'll, on the next slide, we'll kind of talk about, you'll be able to see that, but like the generic term for Lasix. So Lasix is the diuretic that we use occasionally to make the kidneys force fluid out of the body. That particular medication is, the generic name is furosemide. So when you look at the vial, furosemide is what it's called. And then when a company says, hey, I want furosemide and I want to sell it as my own, I'm going to call it Lasix, and sells it. Lasix that is essentially the brand name. So again, Tylenol is a brand name. Acetaminophen is the generic stem or the basic generic name for that. Does that not make sense to anybody? So again, generic, the easiest way to remember this also is if you have if you take a medication, we all know that when you go to the doc, when you go to the pharmacy, the generic meds are usually cheaper than the actual brand name ones, and that can be the same with just buying a bottle of Tylenol. So when you go and buy a bottle of Tylenol from Kroger's, if you buy the brand that actually says Tylenol on the label, the brand name Tylenol, it's going to cost a little bit more because, again, we're paying manufacturing fees and marketing and all that other stuff. If you go over and you find the Kroger brand of the Tylenol, it's not called Tylenol. It'll say in the top corner that it mimics Tylenol or the same chemical composition as Tylenol, but it's just going to say acetaminophen across the label. That's the generic name. That is a generic medication. Same medication, just not proprietary by that marketing strategy. That is really important for us to understand also. We use that a lot in our world. If somebody's having a seizure and I say, hey, go get the Versed is a brand name. That brand name can be something different if that particular Versed came from a different manufacturer that called it something differently. But at the root of it, at the root of everything, that Versed is called midazolam. Midazolam is that generic term that we use for Versed. So please know that there are two different names. There's a generic name, and then there's the brand that actually sells it, the brand name. Those brand names do have to be approved by the FDA. So that's why you don't see a whole lot of different Tylenols. You usually just see the one that has the market share. So here's some more examples. So Lasix that we just talked about. Lasix is that, yeah, there's no, I don't even know what that first one is. I got nothing. So that's a train wreck is what that is, but that's the chemical composition of what that is. Don't care about that, neither do you, and you shouldn't. But the generic name, again, that goes through all manufacturing is furosemide. That is the medication. And then whoever picks it up and tries to resell it under their label, they call it Lasix. The tall man lettering is basically just a fancy way of they'll do this for a couple different reasons, but a lot of it still goes back to making sure that if this particular brand, so diphenhydramine, what is diphenhydramine? What's the generic, or I'm sorry, what's the trade name for that?
Benadryl.
Benadryl. So that's the brand name. They have diphenhydra, all kinds of other stuff. The AMINE at the end is basically saying this is still us as a company. This is still the same generic medication, but again, that prefix is used kind of interchangeably between some of their other ones. So again, I'm not super worried about any of that. What I am worried about is this right here, this generic name versus this brand or proprietary name. So moving through, again, these are just some of the considerations when we're starting to roll through the selection process. And again, this doesn't really affect any of us. And to be honest with you, reliability is really all I care about. I need to make sure it's safe, and I need to make sure it's reliable. And as a fire department, that's usually handled by somebody else. The PDR is the physician's desk reference. Almost all ambulances are supposed to have these available inside. Some of your departments may or may not, but you should have some type of access to this. And I don't want to go too deep into that, but the physician desk reference is basically if you have a textbook, in the very back of the textbook, you guys are going to use this today if we have time. starting in like the 1400, 1495. However you bookmark, if you have a book and you are a bookmarker, a sticky note or whatever, page 1495 starts the drug profile list. That is essentially what a physician desk reference is. It gives you the name, the category, the uses, like when you're supposed to use it, or the indications when you're not supposed to use it, or the contraindications, any pregnancy risk factors, the dosage, all that stuff. Everything lives here in this physician desk reference. And again, it's online, but a lot of ambulances have it in there, somewhere in there. They also have to provide you with this little packaging insert, which is super annoying when you're on a run because you got all this paperwork that falls out of the box that you open up. But basically, it has all the basic stuff in it. Let's get through some of this stuff. A lot of times with our protocols that we have, we have a separate drug license, and on that drug license, a lot of this information is on there. All the administrative garbage, all that stuff, that's all available. And it's not necessarily going to help you as a care provider. It's the big things that you need to know: what medication, what route do I have to give that medication? There's a couple other ones in there, but basically, is it safe and is it going to give you the therapeutic what you're trying to do? All right. So the American Heart Association, they came out with these recommendations, and these are I don't particularly care too much for these, but basically, like a class 1 medication is a class that they say 100% yes, this works, yes, this works reliably, and yes, this works on all classifications of people, age, gender, whatever it is. This works really, really well. All the way down to the class 3, which is basically this is garbage. Essential oils. There's certain essential oils that can kind of cover the whole spectrum of this classification. So much of the medication world, there is an absolute active ingredient that will absolutely do something to your body on a pharmacology on that particular level. There's also the other side of that, which is kind of a placebo effect. You take a medicine and immediately you start to feel better. Well, you'll see that with patients all the time. I gave fentanyl this morning. It's a pain medicine. I gave fentanyl this morning at 4:30 in the morning for an elderly lady with a broken hip. The second I gave it to her, she immediately felt better. Well, it takes 3 to 5 minutes for that to actually work. So I know it didn't necessarily work, but in her mind it did. So again, the placebo effect, but there's something to be said for that, because if one way, shape, or form she doesn't feel pain for whatever reason, then the medicine is already doing what I want it to do, even though it's more of a psychological standpoint than a physical action potential. So there are different classifications, and it is valuable to understand that there are different classifications. And again, moving down the list, there are some that just and a lot of this goes back to like the off-label stuff. So there's probably weak evidence to show that glucagon is good for that or that esophageal embolus. So that being a class 2B use for that particular medication is a very, very good reason why it's considered off-label, because there's not enough evidence to say that it works reliably 100% of the time. They're going to talk about storage of meds. Basically, the big thing with storage, we put them in a bag, we put them in an ambulance, and we try to keep it temperature controlled. That's really what it comes down to. And I don't want to spend too much time on all of that stuff. But we want to avoid the extreme temperatures. Obviously, if you drop a glass vial, that's not going to go well. Direct sunlight, again, UV light, that affects that. Controlled substances are technically supposed to require some additional security. Each department has a different interpretation of what that means, though. So, for example, a department A might say, hey, all of our controlled substances, which, by the way, if a controlled substance, according to that original chart, somewhere where it falls under the classifications, if it falls under any of these schedules, these are considered controlled substances. So basically, the Valium or Ativan or Versed that we use for seizures, the ketamine that we use for some sedations and pain management, the fentanyl and some of the other stuff that we use for that, all of that stuff has to be somewhat secured. So again, Department A might say that means that I need to put a lock and key, or that means I need to put a seal, or I need to put something like that on the cabinet that it lives in. In some other departments, like for example, like ours, That basically all that means to our department is that we need to have, it just needs to stay in a bag, and there has to be a seal on the bag. So it's not physically secured. It's tamper resistant. It lets us know that somebody messed with it. Security, that's where we were. As far as the DEA, the Drug Enforcement Agency will come and they will do site visits. They'll show up. They'll make sure that our drug license is still active, and they want to see the record keeping. They want to see that we're doing these things. They want to see that we're keeping it secure. They want to see that when we dispose of stuff, we're not just chugging it or we're not just throwing it in the normal trash can. So we do have to try to provide all of that information back to them to keep our drug license. So everything needs to be accounted for, and that's really what they're talking about here. All right, back to some deep stuff. So the physiology of pharmacology. So basically, what it is doing. This is so again, medications are administered to produce a desired effect in the body. That is 100% at the goal. If they have pain, we want to give a medication to correct that pain or to block those pain receptors. If they're having an allergic reaction, we want to address those histamines, so we give them an antihistamine. So pharmacodynamics, and again, this is just terminology that you just have to know. So it's basically this alteration of the function or process of the body. So really, can somebody tell me what that means in normal person talk? No. So basically, this is the dynamic within the body that happens as a result. So again, there's a whole lot of cellular stuff that happens. They have to go, the receptor sites have to be activated. The medicine has to find them, has to bind to them, and has to physically overthrow them. So basically, that process of working through the body and physically working, the easiest way to think about pharmacodynamics is this is it working. This is the process that it takes for a medication to physically work. So again, it has to alter the cells. It has to alter permeability to make sure, some medications, they want you to be able to absorb another medication better or quicker. So things like that. There's a whole bunch of different ways that it can physically function within a body. But the way that it functions within a body and physically what actions is taken, that is what this pharmacodynamics is. And that is really, really important to understand. And because of that, there's a byproduct that's produced. So any medication can have some kind of toxic side effects, because again, for your body to inject, for me to inject as a paramedic, for me to inject a medication into a body that's homeostatic, that has that homeostasis already, they are hanging out, they're doing well. For me to introduce something that goes in there and attacks something, there's some side effects to that. The body wants to reject that. The body doesn't like that. It doesn't like this intruder going in and shuffling stuff around. So there are side effects, and that's where the side effects come from. It's your body literally bucking the system. The other side of that is if I give you a cardiac med that speeds up your heart, well, there's an effect there. It's speeding up the heart. Well, there's a whole lot of stuff that make the heart work. It has to have enough preload. It has to have enough fluid going into it. It has to have enough volume in the system. The pump has to be strong enough, so it has to beat fast enough. So if any of those things are amiss, and I give a medication that forces the heart to beat faster, there's going to be some side effects to that. They're going to become diaphoretic. They're not going to have a good blood pressure. There's a lot of stuff that has to go into making that physically work. So a practical example of this, there's a particular heart attack. It's an inferior wall infarction, so an inferior wall MI. Again, not important to understand that per se yet. But if they're having a specific heart attack and if I give nitro, that's a problem. That nitroglycerin is going to dilate everything. That particular heart attack it creates a problem with the heart's ability to physically pump and constrict anyway. So if I give nitro and I dilate all the blood vessels, all the coronary vessels around the heart, I've just substantially increased the problem of the initial heart attack by giving a medication that doubled the effects of the original heart attack. So again, kind of understanding what we're giving and why and what the side effects are, that can absolutely help us go through the determination factor of whether or not this is a good time for us to give this or not. So how do we give it? These are the 4 basic ways that we're going to end up giving this. And we're going to talk a little bit about each one of them. But basically absorption, again, skin. And we'll kind of go through, we'll kind of go through this. So the body absorbs it. So if I give the injection, if I give it, if it's a pill or a capsule or something, the body has to absorb it. It has to get into the bloodstream. It has to go through the heart. The heart has to send it out through the kidneys, the liver, and some of the other stuff. And that actual dynamic function from the last slide has to happen. That's this biotransformation. It's basically, it takes the medication, it finds out what it's supposed to be doing, where it's supposed to attach, which receptor sites it's looking for. Once it does, it physically transforms that particular receptor site or that cell. So again, pain medicine. If I give pain medicine, so grandma this morning, I gave pain medicine up the nose. So it goes in the nose, it's absorbed into the bloodstream through the nasal mucus glands. It goes into the body. The heart distributes it throughout the body. And everywhere in the body that it finds a receptor site for pain, it grabs it, blocks it, and completely, it just mutes it. So that's the biotransformation. It found the receptor sites for pain and it blocked them. And then at a certain point, your body's going to catch up and say, oh yeah, I know you. I don't like you. Get out. And that's that elimination factor. So that's usually, that happens usually in the liver or the kidneys, and it's usually excreted either by urine, usually by urine. So again, kind of a high level thinking, but I think we all kind of have a good idea of that. And that's kind of how that process, after you administer a medication, that's how that kind of works. So another term, pharmacokinetics. This is the absolute action of the body after the fact. So did it work? What did it physically produce in the body? So this is not interchangeable with pharmacodynamics, the previous one, but they're commonly confused. So the first one is the physical action on a cellular level of blocking the cells, blocking the receptor sites, flicking something to make it work a little bit better, or that is the physical action of the cells. And this is the body's outcome. So again, the pain management, I gave the med, pharmacodynamic goes through, that process happens. The body finds all the receptor sites, it blocks it the way it's supposed to, everything works great. And the pharmacokinetics, or the outcome, is basically she no longer had pain. That she doesn't feel pain as a result of this medication administration. So that is the difference. One is the process, one is the outcome. And it's just going to have to be a memorization thing. So here's some of the receptor sites. I'm not super worried about. I'm not super worried about that. We just meant to find where we pick back up. We just talked about this. So we just talked about the medication binding to a receptor site. Again, that varies. It varies on what you're trying to do. If it's a pain medication, it is specifically looking for those pain receptor sites. If you're looking to increase the heart rate, they're looking 100% for those autonomic, that smooth muscle receptor site within the heart that makes that happen. So this is literally just the messenger system that activates to go find that particular medication. Once it finds it, it binds to it, and it either prevents it from functioning or spikes it to function better or more efficiently than it was before. So at the bottom, very, very important, agonist versus antagonist. I sent something out before, and I think the next picture actually has a really good, there's a really, really good picture here. So in a normal body, this left photo is true. So there's a receptor site, and I'm a very visual learner. So this receptor site has a whole bunch of open parking spots in it for stuff. And usually these parking spots are kind of reserved for oxygen. There's times where the ATP, or what makes this nucleus actually fire off inside this cell, it has byproduct. And some of that byproduct can be that lactic acid or something like that. So what it does is it pushes that lactic acid up and out into one of these parking spots, so that we have the ability to basically excrete it through the bloodstream. So these are used for that. So in a normal person, again, we take Tylenol for a headache. The Tylenol will go through the body. It'll look for these pain receptor sites. It'll find a parking spot that's open, and it'll bind to it. Once it binds to it, the whole pharmacodynamic process is this. And then the outcome, or the pharmacokinetic outcome, is that now my head doesn't hurt anymore because there is a blocked receptor site here because of the medication. So This is referring to, now specific to the picture, this is referring to natural chemicals within the body. So the body naturally naturally produces glucose and serotonin and some of the other stuff that naturally is needed for cellular activity. The big ones that we know is potassium and sodium. So these little, in this first picture, these little green capsules could very well be sodium, just free range sodium particles. And again, that sodium that lives outside and the potassium that lives inside. These are the parking spaces that they flip flop. So when we give an agonist drug, it's basically, so a good example of an agonist drug is albuterol. So albuterol, when you give albuterol to a patient that's wheezing or having trouble breathing, the chemicals, they bind to the intended receptor sites for the bronchial dilation. And basically, this is exactly what it does. It tells that site that it needs to increase its function, and basically it says enhance the cellular activity, and that's exactly what it is. So again, an agonist drug sparks something to work. And if that's how you got to write it down, write it down. An agonist forces something to work or work better or work more efficiently. An antagonist blocks it. So these little mushroom things, it puts a plug in there where nothing else can get in there. This is a pain medicine. So pain medication, that's exactly what it's doing. It's blocking the receptor sites and it stops the ability to sense or to feel pain. I hope that makes sense. If it doesn't, let me know. So the term affinity is basically how easily this can happen. If this can happen very, very easily, there's a very high affinity for that particular medication to bind. So again, affinity is just a term that you're going to use to determine whether or not it works very well or not very well. Some medications like adenosine, which is another medication that works on the heart, it works really, really quick. It has a super, super high affinity. It works really, really quickly. So it finds it works, it functions, and within 30 seconds it's gone and it's been metabolized through the body. So that's a very, very high affinity medication. So specifically, so again, I'm sorry, this is still talking about agonist medications. So again, that agonist, that for some of these cardiac meds and for some of the other meds, how quickly it works and how quickly it can bind. And again, specifically to the agonist, which is forcing those cells to work better or more efficiently. There are some thresholds in here. I don't necessarily want to go. I'm going to go here either, but basically the threshold level, the easiest thing for you to understand about that, or what you do need to understand for that, is if the dose for me for Tylenol is 500 milligrams, and I'm just throwing out the number, if I'm supposed to take 500 milligrams, if I only take 200 milligrams, I am below that threshold level. So that's, the cells in my body aren't going to do a thing with 300 milligrams of Tylenol. It takes 500 for it to even pique their attention. So again, you're going back to this. If this particular cell receptor site, if this little parking spot is not full, it's not going to work. So if I cut this dose in half or half again, and I'm not filling up this entire receptor site, it's not going to absorb it. It's not going to function. So I have not hit my threshold limit on that. So that's kind of important to understand. So threshold level is the level at which that particular cellular activity or that initiation of that pharmacodynamics, that's where this starts right here. Does that?
Adam?
Yes, sir.
Hey, you talking about this? Is that with the whole dividing the kilogram or pounds into kilograms? If you just divide by 2, you may not meet that threshold, quote unquote.
Yeah, that's exactly it. So these cells now. Also keep in mind, I'm keeping this kind of simple, more for myself, but specifically for all of us together. This is a very dynamic. A cell in general or a receptor site it's not round with these perfect little parking spots in it. What it is depending on what the receptor is and depending on what size and what age the body is, these cells have either matured or not necessarily matured. And again, some of these are more pliable than others. So when it comes to the dosing, if I took a child and just divided a dose by 2, instead of me giving something that fits nicely into this receptor site parking lot, it's going to be this monster beach ball. and the body's not going to necessarily know quite what to do with it. So it's going to, the way these cells work is they're going to put 2 or 3 of these receptor sites together and make one giant receptor site, because it's one giant dose that it's trying to take in. So when it does that, you get this giant bolus of medication into this particular cell that's not these nice little form-fit puzzle pieces. So that's why overdosing the patients it's really terrible, because it takes the entire body to say, hey, this cell over here, in this particular parking lot took on this giant molecule of medication, and it's over there losing its mind. So yes, when you divide by 2 in a kid, and you could do that. You could do that on paper on your own. If you took a 50-pound kid and just divided it by, we can do that real quick. So the difference between a 50-pound kid, if you just divide it in 2, just for quick, easy math, you get 25, so 25 kilograms. So if I'm giving 1 milligram per kilogram to a 25 kilogram patient, that's 25 milligrams. If I did it the right way, and I did it by 2.2, we're at 23 milligrams. So I literally gave them 2 additional milligrams of a medication. When you're thinking about milligrams, that might not sound like a lot, but if I told you that, like an adult patient, I only give 5 milligrams of a particular medicine for it to be functioning, 6 and 7 would end up creating a respiratory distress problem. All of a sudden, that becomes a big deal. Those 2 milligrams, that is a big deal, specifically when you're talking about low doses of stuff. Benadryl is another good example of that. So if I have a child and I give 5 milligrams of Benadryl, it's going to snow them. They're going to get tired. They're going to get sleepy. There's a potential that I might have to assist ventilations, and that's with 5 milligrams. Well, we just decided that the movement of error there can be up to 2 milligram difference, just because we didn't divide appropriately. That instead of 5 milligrams, which is already going to snow them, I'm now giving them 7. So that 7 milligrams is certainly going to create a problem. So the dividing by 2 is not necessarily the right way to go. And that's exactly why, because these receptor sites aren't going to know what to do with it. They're not going to be able to handle it. So the potency is the concentration of the medication. How strong are those little green things or those little red things? Are they strong? Are they concentrated? Are they not so concentrated? That is the potency. So potency equals concentration. And that's the concentration of it to initiate this response. So basically, if I give, if whatever medication, if I give 1 milligram of it, and it's in 1 ml, so 1 milliliter of fluid equals 1 milligram of medication, and I give that, and that is the appropriate threshold to get that function, to get that outcome the way I want it. If some medications, what they'll do is they'll increase or they'll dilute it. So basically the concentration will be, to get that same 1 milligram, sometimes it'll be in like 3 milliliters of fluid or 5 milliliters of fluid, or sometimes even greater. So the potency is how condensed or how concentrated that actual active medication is within the fluid that you're giving it. And again, I hope that kind of makes sense. Versed is another good example of that. For me to give 5 milligrams of Versed can be given in 1 milliliter of fluid. That's the dose concentration that I have in my ambulance. So for every 1 milliliter that I give, they get 5 milligrams. Some places they carry the medication in a packaging that allows it's 1 milliliter for 1 milligram. So for me to give the same 5 milligrams, I have to give 5 milliliters. Well, that's a lot more fluid that I have to try to push either through my IV, or worse yet, into a muscle with an intramuscular needle. So again, if I'm going to be pushing fluid into somebody's shoulder, I want the most concentrated medication I can find. Otherwise, I'm going to have this baseball or this golf ball that I just injected under somebody's arm, and that's not necessarily what I want either. So again, potency is the concentration of the medication for us to get to that desired dose. And then efficacy is exactly what it is here. Is it going to be effective in treating the problem that I want it to treat? So did that pain medicine appropriately handle that patient's pain? Was it effective? So efficacy is exactly that. It's did it physically work? I can smell people's brains burning a little bit here. So we'll go a couple more and we'll take a little break. So again, here's some more of this. This is just more of a visual aid than anything. So obviously the higher the dose, the higher the effect. So we know that, right? That there's a max there where anything over that particular max is just discreted through the body. So a good example of that is like vitamin C. When you take a daily multivitamin and it says that you took that particular multivitamin has 100% of your daily vitamin C. When you go downstairs, when you go out and you eat something, you eat a bunch of fruit that has a bunch of vitamin C, your body is not going to necessarily absorb more than what its maximum effective range is going to be. So the more again, all you're going to end up having outside of that threshold, you're just going to have, again, it's just going to be excreted somewhat through the body. So there is a direct relationship. The higher the dose, the higher the effect, up to that maximum range limit. Hopefully that makes sense. Don't overthink this. Honestly, don't overthink this. Really, all we've used some $4 words to basically say this medication is designed to go into the body, find its intended target, attach to it, pharmacodynamics, and then we want the body to physically respond because of that attachment. That's the pharmacokinetics. So that's simply put, and the rest of it, like the efficacy, we know that's kind of, that is the effect. Threshold is what it takes to achieve that actual desired result, or that's the minimum. So some of these terms are, once you put it all together, it's a little bit easier to understand and palate than just to kind of look at it from the beginning. Let's take about 10 minutes. We'll talk about some antagonists, and maybe five or 10. Just kind of stretch and just get yourself together for just a few minutes, and we'll be right back. So we pretty much talked about how everything works together. We talked about agonists, which again, agonists influence the body to do something. Antagonists, it binds to the receptor sites and blocks something from happening. Simple way to put it. Again, agonist sparks something to work better. Antagonist blocks it from working to begin with. Try to let my computer catch up a minute. Okay. All right. So there's competitive and then there's non-competitive antagonists. And this is basically just the different subcategories of something that blocks a receptor site from physically working. This is the biggest thing. Competitive equals temporary. It will temporarily bind to a receptor site. This is Narcan. Narcan will temporarily bind to an opiate receptor site and temporarily block it from doing anything. On the flip side of that, you have the non-competitive, which permanently binds to the receptor site, preventing the activation of it from physically working. So again, competitive basically has to compete for space on there, and eventually it will lose. It is temporary only. So competitive, the easiest way to remember competitive, it has to try to compete for space, and eventually it will lose. Non-competitive, it automatically is the winner. It will automatically bind and it will automatically stay there. So partial, I don't want to get into partial. Let's skip that. Drug action, we talked about this. We talked about that already. All right. So here's some of the, well, let's go back one. So here's some of the other drug actions. Sometimes, so medication, we know it either makes it work better or it blocks that receptor site altogether. Here are some of the additional ones that do something a little bit differently. So microorganisms. So it's looking for, so an antibiotic. There's nothing inside the body. There's no receptor site within the body that an antibiotic needs to go find. It needs to go find that antigen. It needs to go find that issue or that microorganism. Lipids, it needs to go find the fats that are floating around in the bloodstream. It needs to bind to those and excrete them. Water needs to force the body to get rid of the excess fluid on the body. And in toxic substances, we're not going to get too deep into that, but so know that agonists, antagonists, and then these are kind of the other category. So antimicrobials. So again, antibiotic cream and things like that. So we keep talking about medications as if they're all parental. That I can't even pronounce the word. The parental or parental or that word. That particular word. So really, what this is, we got to remember that there's other stuff. There's eye drops. There's topographical. There's skin. There's all of those patches and all the different things that we were talking about earlier. There's a whole bunch of different stuff. So this kind of falls into some of those. The chelating agents. This is not something that we're really going to worry about, at least in the United States. Some of the older houses and the lead poisoning and stuff like that. This is one of those agents that will bind to that. I don't know that it'll get into it, but there used to be activated charcoal, which you would drink it and it would get into the stomach and it would find everything in the stomach, try to gelatize it, make it kind of like firm, and make it basically forces the patient to puke up everything that's in their stomach. So that's one of the options for. That's just a different type of agent. The sodium bicarb that's on there. Sodium bicarb is a medication that we can give, but it's also something that's naturally occurring in the body. This might be a test question, but bicarb within the body is what the body uses to adjust pH. So if the pH is low, they're acidotic. Remember, anything under 7.35, they're acidotic, and the body produces this sodium bicarbonate. Bicarb is what fixes that acidosis. So the body will release bicarb. Bicarb will bring that pH, or that hydrogen ion, that pH, it'll bring that pH up into that alkalic range that it needs to be in. So we can give bicarb to basically to kind of force the body to do that. Diuretics, again, Lasix. This is something that basically this osmotic shift or this osmotic change, it basically forces the fluid from the high side of the body into the low side of the body, which again is just a way of excreting additional fluids. The problem with that is exactly what the second point is there. If I'm excreting extra fluids, then I'm excreting potassium and sodium, whatever other minerals are floating around, the free range items that are floating around in the bloodstream and in the fluid. So usually what ends up happening, the diuretic, it works directly on the kidneys to force the kidneys to excrete additional fluid that it normally wouldn't. So again, that's something that we can kind of mess around with a little bit with the Lasix. There are some electrolyte, we can give potassium, we can give calcium, we can give some of those. We don't, magnesium is another one. The big ones that we do in the field, we will give magnesium for a couple different things. That is an electrolyte-based medication. And then so magnesium and calcium are the two that we will give in the field. And again, I don't want to get too deep into those just yet. So these are basically the big things that we have to try to remember. These are very, very important for us. You got to pick the right medicine. We have to figure out what the correct dose is. We got to figure out the route of administration. So is it a pill that they have to swallow? Do we have to give an injection? Do we have to take the time to set up IV therapy stuff, start an IV and then give an IV? And then basically, do we have to give it quickly, slowly? Do we have to send it in with a saline flush behind it, like to chase it in? What is the manner that we have to administer it? And then we have to be able to monitor the patient after the fact. So did we have the correct results at the very end? You will see there's going to be a cheat sheet for the 6 rights. So you're going to RIGHTS. So the 6 rights for giving a medication. It's going to be very, very similar to this. And again, it's the right medication and the right dose and the right route and the right timing, basically the right action potential, and did you give it the right way? So we'll talk a little more about that moving forward. Some more stuff about just some adverse reactions from the medications or with the as far as a response to the medications. Again, some the age in general, that can mean a bunch of different things. in general, kids have the ability to metabolize medication really, really quickly. On the flip side, elderly patients, their metabolism doesn't really work at all. So that medication that you give may stick around in an elderly patient far longer than it'll stick around in a pediatric patient. Weight-based, we've kind of scratched the surface on that a little bit, trying to figure out how to make that work. Some of the next levels that you'll get into are on some of those practice tests. And again, don't get too far into that, but we're basically, these weight-based medications, it's going to be a very, very specific dose for that specific sized patient. Kids, for some reason, kids are a majority of the doses that we give kids, a majority of the medications are going to be weight-based. There's a couple exceptions to that, but overall, it's likely going to be a weight-based medication 100% of the time. Since I mentioned it, and since we're physically in this, we're not in pediatrics yet, but I have an app that I wanted to mention to you guys. The app itself is, and I don't know if you guys can see it, it's called PD Stat, S-T-A-T. It is a paid app, so I don't want you guys to, I'm not going to tell you guys you have to go get it. But what I will say is that particular app I use on a regular basis. I may post a link in the Schoology for it. But basically, you can tell it how old your patient is, and you can tell it what they weigh, either or. You don't have to have both. So you can just say a 4-year-old, and it'll ask you what the problem is. So you click on a 4-year-old, they're vomiting, or you need something for pain or whatever it is. You click on it, and it will automatically give you the weight-based range for what the threshold is for the minimum effect, for that minimum efficacy. So it'll give you that threshold. It'll also give you a maximum dose, and it'll tell you what the appropriate dose range is. It'll also calculate your kilograms, and it'll automatically apply those kilograms to that dose and give you a physical dose to give the patient. So it does all the math and all the thinking for you. So on the fly, I really, really like that. There's some exceptions that we'll talk about later. Or why the exceptions are the exceptions, but basically there are times where our protocol wants us to give a dose that's higher or lower. So just some things to kind of think about. But that's a really, really cool app for that. More stuff. Again, some of the limitations. The patient's weight. Again, you got to do the extra step of converting it to kilograms. That app does it. For the adults, doesn't necessarily do that. And again, this varies greatly. The other example is if you have a 400-pound 25-year-old, that's very, very different than a 150-pound 25-year-old. So again, a lot of the weight-based medications, it's very, very important to get that right, just simply because of the size and stature of the patients. So here's some other stuff that's really important. So in the environment. So if I give somebody, in general, hypothermia. So talking about hypothermia for a minute, if you remember a few years back in the city of Hamilton, there were 2 firefighters that were doing some rescue drills at the dam, and both of them ended up going underwater, and both of them had near drowning events. They lived despite being underwater for way longer than any human being should be able to do that, to be underwater without oxygen. The reason they did that was because they were hypothermic. That water was really, really cold. So the second they hit that water, the second they lost consciousness, their body went into that full it was a full parasympathetic response. So their oxygen demand in their heart went down. The oxygen level that's needed in the brain went down. Everything kind of went into rest mode. And they went unconscious, and because of the hypothermia, that metabolism just wasn't physically working. Well, this is important to understand because in the wintertime, when we find, frail grandpa sitting outside and he's, frostbitten and, he's been, whatever, dementia, whatever it is, when we give medications to him, that medication is not going to probably have any effect at all for the first however long, because his body is not metabolizing it. It's just floating around the bloodstream. That ability, the ability for the receptor sites to open those parking spaces up and let that medication in is slim to none, because everything is in shutdown mode. So that's really, really important for like our non-breathing hypothermic patients. So if you have a post-drowning or a near drowning and you drag somebody out and they're unconscious, they're in a full cardiac arrest, when we're given that epinephrine or we give medications, we have to try to remember that because they're hypothermic, that medication that we're giving is not going to have its intended effect because, again, their body's just not going to metabolize it. On the opposite side of that, the hyperthermic patients, it's going to go quickly and they're going to burn through it because their body is ramped up. They're in that sympathetic response. They are rocking and rolling. They're everything that we throw at it, it's trying to process and get rid of immediately. So those patients, things might wear off a lot quicker. There's some genetic stuff that's not super important. There are some people that have allergies to medications that could kind of fall into this. My wife had a surgery. It's been quite a few years now, but she had to have her appendix taken out, which wasn't a big deal, except when she went in. She went up to the OR. They got her all set up. They got her prepped, and for whatever reason, they needed to intubate her. So she was intubated. I get the doctor that comes out to the waiting room, like, I don't know, 15, 20 minutes into the procedure saying, so we're done, but there's a snag. And, you don't ever want to hear that. But they came out and they said, so basically my wife, there's a protein issue in her liver where the medication that they gave to sedate her, they give two medications for that. There's one that sedates you mentally, and then there's one that physically paralyzes your body so that you can't physically move. And as awful as this sounds, the succinylcholine, the one that sedates your brain, that wore off, but the one that paralyzes you so that they can put the breathing tube in and stuff without a gag reflex, that didn't wear off. So she was essentially awake. Mentally, she was awake, but physically couldn't move at all. And then you can start thinking about how awful that would be, especially with a breathing tube and stuff like that. So she kind of explained that she was on a vent. So every time the vent would breathe for her, she would feel her body take that breath. She'd feel her lungs expand. But when in her brain, when your brain says, hey, take a breath, you need a deep breath, she would try, but she couldn't. And then on an offbeat somewhere, that ventilator would actually breathe for her. And even worse than that, they were trying to figure out why she wasn't coming to. So they had this little shock stimulus. It was a little pen that gave like a little electrical shock. So they usually do that to try to stimulate a response, like a painful stimuli response. So she can tell you today that she felt everywhere they poked her with that stimulating response, but she couldn't physically say anything about it. She couldn't stop it because she was still physically paralyzed. So is awful. That is absolutely terrible. But what the take home from that was everybody in her family has this sensitivity to that particular medication. We didn't know that. So there is absolutely a genetic factor that had we asked the right questions ahead of time, we would have known that she has that hypersensitivity to that particular medication. And because of that, she needs like a partial dose, not the full weight-based dose that they gave her. So that is absolutely a thing. In the field, we may not know that. What we will know, though, is that some people have some kind of significant intolerance to pain medicine, for similar reasons. Pain medicine, it makes me nauseous. It makes me throw up. Everybody in my family, I'm hypersensitive to it. So give me half a dose or whatever. And those people will know that. They'll be able to articulate and tell you that. Pregnancy brings a whole nother complication to it. This is a whole nother complication for a whole lot of reasons. There are indications in the medication section when you're starting to talk about it for like special considerations. Some medications you absolutely cannot give to a pregnant woman. Just can't happen. It can get into the baby system and wreak all kinds of havoc. So pregnancy in general is going to be its own. It has its own set of rules. If in doubt, we call medical control. We say, hey, we have, a 31 week old, 25-year-old female, blah, 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 blah. This is what I need to give. What is the dose and is it appropriate? And they will be able to tell you over the phone whether that's appropriate or not. Also, by the way, pregnant females, they've got a dramatic increase in blood volume and total volume in their body. So the typical weight-based drug dosing may not be enough because, again, there's a lot more fluid in there. So we know from before the concentration is a big deal. So that concentration of medication within a body that's filled with more fluid than you expected is going to dilute that. So just again, pregnancy is its own beast, and for a couple of days we'll deal with that later in the year. All right. so these are the classifications for the pregnancies. This is basically the use. It's basically the go no go for giving that particular medication. So a class A is exactly what it says here. So there's plenty. The key term there is plenty. There are plenty of controlled studies that show that that there is absolutely no risk to that particular fetus. That is a safe medication. You won't see a whole lot of those because there really aren't a whole lot of those. Because mom's circulatory system is tied to baby's circulatory system. There's a lot of the medication, almost everything that mom takes in is going to cross into the baby, into the fetus. So there's not really a whole lot of A's out there. A lot of them are B's, where basically, for the most part, they can say, with air quotes, that we're probably in good shape and it's not that big of a deal. There are some times where there's going to be some complications, but again, if there's one or two of them, like nationwide or study wide, they're not too typically concerned with that across the board. So just know that there's a chart. There is a chart for pregnancy medication classifications. Skip through this. So therapeutic effects. I skipped the slide about the psychosocial. We know that there's some people actually take medications for a reason. Some people take it because it makes them feel good. Some people continue to take medication after it's been prescribed because they like the sensation that they get from that. So that's obviously going to be a problem. Specifically, what it's not saying here is like the drug seekers. They absolutely they need that, they want that, but they don't physically need that. So the therapeutic effects, again, there are times, and a lot of this basically comes back. This is going to circle all the way back to the very beginning with the toxic or the excessive use. So if I give that pain medication, it works great. It works great. It binds to those receptor sites. It blocks. It's an antagonist, so it blocks those pain receptor sites. The body doesn't feel the pain. So essentially, we have achieved the pharmacokinetics that we wanted. But if I continue to give it and I continue to flood the system and overwhelm that receptor site or those receptor sites, you end up with the side effects. Well, a side effect to too much pain medication is unconsciousness. Well, that's a problem. To further complicate that, the next step is apnea. So they're not breathing, or they're not breathing super well. So those are obvious side effects that come because we have exceeded the maximum therapeutic dose. And that's what that's saying. Side effects, we talked about that. Excuse me. The big thing with meds, when you ask somebody what their allergies are, because sample says we have to ask what allergies are, it's actually really, really important. When we ask about the allergies, every patient will tell you that, oh yeah, I'm allergic to codeine. Well, what's it do? It makes me feel funny. Well, that's not an allergy. That is not a triggered histamine response in the body that creates a problem. That is a sensitivity. They're hypersensitive to it. Excuse me. So adverse medication effects, these are side effects. Again, they're not necessarily allergies. Some of them are just simply intolerances or they're hypersensitive to it. Let's skip through some of this. Too much coffee. Let's skip through some of this. So the therapeutic index, again, we know what the therapeutic value is. We know that is the baseline or the bottom. That is the floor of where the medication actually starts, where that starts to physically work. We know that we start to move up. There's the therapeutic dose, and then that moves ultimately into ultimately to an overdose. And there's a big difference somewhere in between there. And that's kind of what this is talking about. And again, I don't really care too much about that. And again, I'm going to try to point out the stuff that's really, really important. We already talked about that. Hang on just a sec. All right. Well, I'll tell you what, give me just a minute. I'm gonna go get some water real quick. I'll be right back. All right. My God, this medication chapter is trying to kill me. All right, I'm alive. Sorry. Thanks. All right. So medication tolerances. We know like alcoholics, they build up a tolerance to alcohol. Drug addicts, same way. Ultimately, the dose becomes higher. They need more. When they need more, a couple things happen. The body ends up looking for it, and when it looks for it, it usually has a hard time finding enough of it. So, specifically with pain medication, they'll get their dose, and then as well as I do, ultimately that dose has to continue to start to increase because again, the body looks for it. It knows what it needs, and it needs to find more to satisfy the same response. What ends up happening though is, again, the body's got a really, really neat way of saying, yes, I recognize this med. I don't like it. It's something from the outside. It's not something that's normal for me. So that's typically why it requires more the first time it tries to ignore it. So that very bottom one, that tachyphylaxis, that's a fancy term of basically saying, I took ibuprofen, it didn't work. So within a really short amount of time, I took it again. Well, the body's going to say, well, I already saw this and I saw it a half hour ago. So we're going to kind of ignore the second dose and your body's going to excrete it. So basically it's just a way of saying you've double dosed yourself. In a lot of cases, it has the ability to recognize that and create that immediate tolerance. Are there any questions on that? For that matter, anything else so far that we've covered? No? All right. All right. So because of that, that leads to abuse. Because people know that the tolerance gets high, they know that they have to take a lot. So the next time they take medication, they need to take more of it because, if I hurt today, the more I take, the better. We know that that's not necessarily the case. But stimulants and depressants, and there are some other things out there that pain medicine is really the big one that becomes very, very abusive. Specifically because a lot of times it's more habitual than anything. They like the way it feels. They want to feel that way again. So almost as a form of habit, they do it again. So the next couple things, again, I keep talking about the that section in the back of the book. But the big thing with the meds, we have the class or the name, the indications for it. There's the contraindications, and then there's basically these interactions. So the interactions are basically what they don't do well with. So basically, if I have two different cardiac medications and those two cardiac medications do two totally different things, when that receptor site receives a medication from two different directions, it doesn't know where to go or what to do. So one or the other will usually take the lead, and one will work and the other one won't. At certain times, they will potentiate each other, which means they'll both win. They'll both get into the cell, and you'll have almost double the outcome, which can ultimately become a concern. Any questions on any of that? Nope. Okay, so a little bit deeper into the pharmacokinetics. Again, this is the body's ability to physically move this stuff around and then ultimately remove it, remove the medication from the body at the very end of it. And that duration, a lot of that is determined by how big the dose was, depending on how I give it, and basically what the patient is doing. If the patient's hypothermic, they're not absorbing it, they're not metabolizing it, it's not working. Likewise, the dose, if I give a giant dose, then there's a lot of it available in the body. That dose can continue to be absorbed as the old absorbed medication starts to diminish. And in the route, if you take a pill, the stomach has to break it down, has to send it down into the small intestines. The small intestines have to start absorbing the medication, and then it has to go through the bloodstream. That can take 30 to 45 minutes sometimes. So if I give it IV, it can happen within 30 seconds. So really, really quickly. So again, its ability to affect the body and the duration depends on those main three things. So the onset of the medication is when it physically starts, when it starts to work. It starts to work as soon as it's absorbed, distributed, and that biotransformation happens, where the cell knows that it's been blocked, or that it's been antagonized, or that it's been stimulated to work harder. The peak is when the body has 100% or close to 100% of the receptor sites that are related to that particular problem covered with the medication. So again, the pain receptor sites, the peak of pain medication, the peak of that administration is when all the pain receptors are dull, when all of them are muted, when all of those are dealt with. And obviously the duration, that's 100% related to the patient's metabolism and ability to physically eliminate it. The term at the bottom is something I want you guys to know, bioavailability. So bioavailability is basically, by the time I take that medication, I pull it out of a vial, I stick it in someone's arm, I push it into their arm, and it floats around into the bloodstream. The percentage of that medication, the second I put it anywhere, it starts to lose its effectiveness. So if I stick it in somebody's arm, some of that fluid, some of that medication is going to be absorbed in the local tissue. It might not necessarily make it to the bloodstream. In the IV, if I give a medication via IV and I put the IV, if I put the IV down in somebody's hand, by the time that medication makes it through all the circulatory system and then back to the heart, there's a percentage of that medication that's missing. It's been absorbed elsewhere. It's died off. It's no longer active. So bioavailability is the percentage of unchanged medication that physically reaches the circulatory system. So how much medication out of this vial that I just put in your body is physically available for the receptor sites by the time it makes it there? Does that make sense to everybody? All right. So we're going to start talking about some of the routes here. So oral medication, they have to be able to swallow it. They got to be conscious. You can't shove a bunch of pills in an unconscious person's mouth. It doesn't work super well. They have to have the ability to have a connection there. So some people that have feeding tubes and things like that, clearly you can't do that. So orogastric is basically a feeding tube that goes in the mouth. A nasogastric tube is the same thing. It's a feeding tube, but it goes up through the nose, down into the stomach. And that medication can be given that way. So basically, oral medication goes in the mouth and into the stomach and has to absorb from there. Endotracheal is basically a medication that can go down an ET tube or a breathing tube. Once that intubation tube is placed, you can physically put the fluid, put the medication down in the tube. It'll get into the lungs or into the bronchial tree. it'll absorb there, and then it'll be able to be sent out systematically, pretty much from there. There's a huge problem here, though. Look at the bottom one. 5 to 10 ml flush with sterile water of normal saline. That endotracheal tube is in the lungs. It's placed in the bronchial tree. You're asking me to put 10 mLs of fluid into somebody's lungs, and that's not even counting the medication that was sent. So that basically, to me, that's scary. To a lot of doctors, that's scary. A lot of people don't like to do this. Flushing that 10 mLs of fluid down a tube is ridiculous. A lot of the small dose medications, the super hyper concentrated, whatever it's a super concentrated medication. When you send that down a tube, a lot of that medication sticks to the inside of the tube. It stays there, which is where the flush has to come in. You have to be able to flush it out of the tube and physically into the lungs. And again, we're putting fluid intentionally into the lungs, which doesn't sound like a super awesome idea. Intranasal, this is the Narcan or the fentanyl. This is absorbed really, really quickly. Inside the nose is super vascular, so it gets into the bloodstream pretty quick, and the bioavailability is close to 100%. So by the time it makes it back to the heart, almost 100% of that medication is intact. That's phenomenal. And no, there's no needle stick because it goes on the end of a MAD device. Intravenous the bioavailability is 100% because you're sticking that medication directly into a peripheral access point. And we'll talk about IV stuff later. But this is almost an immediate response. So as soon as it gets into the bloodstream, it's already wreaking havoc or doing whatever it's supposed to be doing. There are several limitations because you have to start an IV to get it. IO is almost the same as IV as far as bioavailability. A lot of people don't think so, but when you're sticking medication directly into the intraosseous area of a bone or of a long bone, that can typically that typically gets into the bloodstream pretty quickly. Obviously, if the bone's broken, you can't do it, so contraindications are pretty great there. Intramuscular, like I said, the bioavailability starts to drop because you're sticking it in the tissue, and it has to make it from the tissue into the bloodstream to be able to circulate through the pump. So we typically inject it. The injection sites are the deltoid, somewhere up in here, or the quadricep on the top of the thigh. A lot of our medications can be given intramuscular, but again, this is specifically for like chemical sedation. So if somebody's freaking out and we have to tackle them and try to sedate them, this is typically where that's going to happen because they're not going to sit still for an IV start. So you got to stab them. You got to do the IM. Subcutaneous. We don't do this in the field anymore. This is kind of a big thing for insulin. This is a big thing for like allergy shots. If you guys take allergy shots or you know anybody that does, it's very, very similar to an IM injection, but it goes into the subcutaneous level of fat. So back to anatomy and physiology, we're not getting down into the deltoid muscle, or we're not getting into the abdominal muscle or the tricep muscle. We're just getting into the fatty tissue or the subcutaneous tissue. Very, very slow absorption because, again, it's in the fatty tissue, which is not super conductive of fluid. So it'll just kind of hang out there and slowly be absorbed, which is why insulin and things like that are great to go here, because again, we don't want that giant bolus of insulin going directly into the body. Dermal and transdermal are patches. They can stay on for a long time. Does somebody have a question?
Yeah, Adam, is the subcutaneous like when they give you the TB, or is it deeper than that?
So that's actually a really, really good question. I don't know. Before I answer that, let me make sure it's not coming up here. So if you feel your deltoid muscle, the easiest way to do it is if you stick your hand behind your back and stretch it behind you as far as you can to the other side, you get a very, very pronounced rounding of the shoulder. That is all deltoid muscle there. If you do your tricep, if you pinch the bottom of your tricep, you should be able to get a flap of skin somewhere in there. If you pinch the skin in half, like just kind of pinch it together the best you can. At the point of that pinch that you've got, that's where you would normally stick that needle in. But it's going to go deep enough that it goes into this fatty tissue that's down underneath here. With the TB test, you're literally going just right under the skin. So they barely poke it in, and they stick it right under that epidermis, like the outside, and then once they stick it in there, it bubbles up. The insulin and the subcutaneous stuff, it's not going to bubble because it's actually down below all that and it's in the fatty tissue. So those are actually technically those are two different injection sites. We don't do the latter though. We typically don't even do the subcutaneous anymore. You guys are going to do a couple of them though in the ERs because people still need insulin there. The transdermal, these are like nicotine patches and fentanyl patches and nitroglycerin patches and stuff like that. I've had a couple overdoses now where there's suicide attempts where people will literally take their patches, they'll crumble them up and they'll stick them in their mouth for whatever dumb reason. And that ends up getting, that's bioavailable pretty quick also. And that's a pretty big bolus of that medication. So otherwise, if, again, like I said before, these patients are the ones you're going to want to search and see where these patches are, and try to get rid of them if you can. Sublingual, this is your nitroglycerin tab. This goes sublingual, which is under, and then lingual is tongue. So it goes under the tongue. This usually takes a greater dose because it has to try to absorb through the mucous membranes in the bottom of the mouth. So sublingual, again, this is nitroglycerin more than anything. This is also somewhat related to the Zofran tablets that a lot of us are carrying now, but they are very different. So sublingual will automatically, it'll start to absorb through the bottom of the mouth. Obviously, they have to be alert and all that stuff. The oral dissolvable tabs like Zofran, melatonin, if you take melatonin or you ever have, those sit on the top of the tongue. They actually take saliva to break down. And ultimately those oral dissolvable tabs, they turn into a powder and you end up swallowing it just with the excess saliva in your mouth. So ultimately those oral dissolvable tablets are still, some of it is absorbed through the mouth, but a lot of it is still an oral medication. Unlike this one, where this one is truly, it absorbs through the floor of the mouth. Again, that's a nitro. Inhaled, we know what that is. Right now that's frowned upon because of the old COVIDs. But this has to be nebulized, and typically it has to be done with some kind of positive pressure, either oxygen or room air. Rectal, we already talked about that. 90% bioavailability because again, it has to make it through a couple layers of tissue to get into the bloodstream. Ophthalmic, these are like eye drops, tetracaine, things like that we carry. And then hemodialysis is basically where they'll take blood out of your arm, they'll inject medication into that blood from a machine, and basically it's a closed loop circuit where it'll put that blood back. So basically they're introducing, essentially it's IV, but it's done by way of a machine. So typically we don't use any of that stuff. We don't use any of that hemodialysis stuff. And a lot of the other ones we don't use. So our biggest ones that we do, the ophthalmic for the tetracaine eye drops to numb an eye, like an eye injury. We'll do IV, IO, intramuscular. We do the intranasal and the oral. Those are, and sublingual. So pretty much all the other ones that we've talked about, we do have medications that fall into those particular categories. So we know how it moves. We talked a little bit about that. I don't want to go too deep into some of this stuff. So osmosis in general, back to biology, chemistry, back to school. We use this to change the interstitial. Interstitial is a fancy word for saying fluid that doesn't belong or doesn't live in the vascular system. So any of the fluid that lives outside of the cells that create that edema. So edema in the legs, it's all that accumulation of fluid out there. The ability to physically shift that from where it wants to go, basically upstream into somewhere where it doesn't necessarily want to go, is osmosis. So this is basically a big thing with the kidneys, and we'll talk about that when we get to kidneys. Speaking of the kidneys, filtration, a lot of this stuff, this has to go, basically the fluid has to push through semi-permeable cell membranes. So if you think about a coffee filter, you pour water in there and it will slow trickle out of there. You're basically forcing fluid. In a coffee pot situation, it's more gravity, but basically you're forcing fluid against that semi-permeable. It's permeable, but not quite. It's not like an open garden hose. And basically that is what filters things out. It's that semi-permeable cell membranes. I'm going to move forward from here. Capillary walls. This is basically talking about the medication moving from the basically from the body into the blood, and then from the blood into the cells. The big thing to talk about here is the blood-brain barrier. You need to know that. Blood-brain barrier is the membrane that allows that medication to exit the bloodstream or blood flow in the vascular system and get into the brain for function, for some kind of action. So again, it's exactly what it says here. It's the ability to get from the bloodstream to the brain. Blood placental barrier, that goes almost without saying, but basically that's fetus. I'm going to skip ahead some. Biotransformation. We talked a lot about that already. And I don't want to go back into that, but again, biotransformation, just to bring it back, that is related to that pharmacodynamics. It's that the medication physically binding to the stuff that it's supposed to be binding to. I'm trying to skip ahead for time because we don't necessarily need it. So elimination. So again, the two big things that are going to affect the elimination, or to assist the elimination, the organ systems are the kidneys and the liver. Those are the two really, really big ones. A lot of times what ends up happening, the kidneys will, it usually takes the first crack through the liver, and then ultimately it'll go into the kidneys, and whatever's left, the kidneys will filter out. And again, this all depends on how long that medication has been floating around the bloodstream. It also depends on how many, what the actual bioavailability is, because as that medication starts to wear off, if there's still more of that medication floating around in the bloodstream, it will reattach as those cells start to drop off the old used ones. So those old used ones, again, they get filtered out through either, again, the kidney or the blood or the liver. All right, here's something to know. Write this down. So half-life. So how long does it take a medication to lose 50% of its effectiveness? So if something has a half-life of 1 hour, in 1 hour, 50% of it will be gone. Very, very important to understand. So if the half-life is 1 hour, again, 50% of it will go away. In the next hour, 50% of that will go away. So hopefully that makes sense. So if you give 2 milligrams of something and the half-life is 1 hour, in 1 hour, instead of 2 milligrams, the body has 1 milligram active in the body. After the second hour, you cut that number, and that goes down to from 1 to half of a milligram. So again, every hour you cut 50% off of what's available, and ultimately you'll have none left. And that's exactly that's what's important for half-life. The half-life of adenosine is 30 seconds. So 30 seconds, that has to get into the body, into the heart. All the pharmacodynamics has to happen, and the actual response, all of that has to happen within 30 seconds, or else at that 30-second point, our drug dose just got cut in half. So that's pretty important for us to understand. There are times where we'll give a higher dose and a quicker interval just to try to combat that. Adenosine is it's a very good example for that also. We'll give a quick dose. We'll double the dose the second time. And if the first dose wasn't effective, just in case it was because it died before it got to where it needed to go. There's a lot of stuff about medication errors. Really, here's the thing with medication errors. I had a national registry question last year that basically asked, it said, you accidentally double dose your patient with aspirin. What is the first thing you do? And the answers were like, document it on your report, tell your partner, call your station officer or whatever, or tell the hospital. Well, obviously, I don't necessarily care about my report first. Ultimately, we're gonna have to document it. But the answer to that is you're gonna want to tell the hospital, like, hey, that is the first step. You can't take it back once it's given. So you tell them like, hey, I accidentally double dosed the patient. You have to rat yourself out. Like that has to happen, or else there's going to be some significant issues if they end up having to figure that out later. So you're just going to tell them, and then you're going to document it. And really, that's all there is to it for that. There's ways to reduce it. The biggest place that we are at risk for this is when I ask you to draw up a medication for me while I'm starting an IV. So if I say, hey, draw up 4 milligrams of Zofran, and you hand me a syringe, and all I have is a syringe in my hand that I'm gonna go ahead and put in. I haven't confirmed it. I haven't double checked it. I'm just 100% trusting this other person. And there are times where that doesn't necessarily work. So a lot of times we have that closed loop communication, and it's basically, hey, I need 4 milligrams of Zofran IV. And my partner will draw it up and say, here's 4 milligrams of Zofran IV. And he'll hand me the syringe, and he'll hand me the vial that he just drew that syringe out of. So I know for a fact, I can look at the vial and say, yep, that says ondansetron, which is that generic name so ondansetron, and then I've got the syringe here. So that is the easiest way to stop that. Any questions on that? All right, let's talk about some specifics. So the sympathetic system. So if you're a note taker, this is where you kind of start writing some stuff down. So sympathetic system, this is the fight or flight. We can chemically activate that. I sent the email out that has this information on it. This is super, 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 super important to understand. Beta 1, you have one heart. So beta 1 drugs are drugs that affect the heart. Now in this chart, if you look at it, there's a bunch of different other $4 words in there. Chronotropic, that is super important. That is a medication that increases the heart rate of the heart. So that is a rate drug, a rate affected drug. The next one is inotropic, which is the contractility. So it makes the heart beat harder. So an example of like chronotropic, epinephrine. When you give epinephrine, again, that's kind of a shot of adrenaline. That increases the rate. That also increases the contraction strength, or the inotropic side. And lastly, dromotropic is basically the velocity. Again, that is how completely. I'm trying to think of the easiest way to explain that. Basically, it primes the entire heart to better send the signal up and down. So it increases the cell permeability is the technical term. But basically it allows, if part of the heart is starting to get kind of lazy, a dromotropic medication will basically stimulate the rest of the heart to go back to basically its infant stages where it was working really, really, really well. And those are also sometimes considered like cardiac protectant drugs. So like magnesium and digoxin, and in some cases, there's a couple other ones, but basically it increases the ability for that heart to physically receive the conduction beat, or that electrical signal. So again, sympathetic, we have to know beta 1 alpha. Alpha is the constriction. Those alpha receptor sites live in the arteries, and it causes vasoconstriction. Or it acts on the constriction of the arteries. And then beta 2, again, there's 2 lungs. So beta 2 is for lungs, so bronchial relaxation. And again, the beta 2 is like the albuterol. Very, very important. And again, the three terms for the heart, that's also very, very important for us to try to remember. Any questions on that? Because again, that is super important for us. Nothing? That lives, if you're in a textbook following along, page 650. There's also the page before that, 648. There's a whole chart for the rights that they're, instead of 6, they're up to 10 now, and that has to do with refusals and some evaluations and some other stuff, but that's unrelated. So back to this. So again, know those 3 terms for the heart as it relates to the sympathetic system, and this is just a fancy term with some pretty sweet green smiley faces in there. We talked about that already. So this is the inotropic is I'm sorry. So rate, force, and automaticity. Those are the three sub, basically the definitions of the other 3 words that you already wrote down. And that's really, this is just a child way of kind of putting it. So I'm gonna skip ahead. So here are some options. And these are some examples. And I don't know that we're gonna have time per se today to go over some of these specifics. But again, these are just some of the ones that we actually do use on a regular basis and that we do carry. All right, so airway system. Some of the sedatives, we use those again to either paralyze or sedate somebody so that we can intubate them. And etomidate is one of the number one medications that we use for that. Again, this lives in the back of the book, so you have the ability to you can look this up on your own if you want more information on this. And a lot of these are just going to go through like some basic drug cards for us. So I'm going to kind of breeze through some of these, and these are just we're kind of going in the intro to some of the meds that we're going to use. And again, you guys are going to do a lot more of this later. Ketamine is technically considered a disassociation medication. We do carry this in the field. Basically, this is a medication that doesn't affect their hemodynamic system, like the blood pressure and the heart rate. It doesn't typically mess with any of that. Rather, it tells their brain to completely disassociate everything that's going on right now. So basically, they can cut their arm off, all the pain and all that stuff. You give them ketamine, and they look at that, and they have no idea what they're looking at. They cannot make a connection that there's pain there. They can't make a connection that I just lost my arm. They just look at this, and it's just a thing. It's just an arm. And they don't really have the ability to rationalize what they're actually looking at or what they're doing. So that's something pretty interesting for us for that. I'm going to skip a couple of these because if we got about a half hour, I'm going to have you guys look at some of these separately. But flumazenil, this is the only thing that can reverse a benzo. So, and some of this we will revisit. But if I give too much fentanyl is an opiate. I can give Narcan. I can fix that. If I give too much of a benzo, like a Versed or a Valium or an Ativan or something, this is the medication that I can give to reverse that. The problem is it's extremely rare. It's hard to find, and it's super, super, super life-threatening to give. It's a very, very dangerous med. It's one of the more dangerous ones that they physically use. So that's not something that I'm going to be super, super happy about using. Paralytics. We talked a little bit about some of these. So again, the first one was a sedative. The second one is a paralytic, and those are the two medications that we have to do for a rapid sequence intubation. So if somebody's talking to you and you have to take their airway, you have to sedate them, you have to paralyze them, and then you have to put the breathing tube in. And that's all stuff that we'll go over in lab and in class. I'm going to skip through that. So here's that paralytic. So succinylcholine is the most common one that's used for this paralytic. Some of the local townships do carry this, and some of the local places still do use this. And again, this is used in conjunction with the etomidate. And again, this is the paralytic, and the etomidate is the sedative. And if all this sounds like Greek to you, it's because it is. I wouldn't worry too much about that, or about not quite understanding some of this. So still on the airway, some of the airway medications. Corticosteroids are medications that basically tells the body to reduce inflammation. So we do carry one of those called solumedrol. Vasoconstrictor is basically that is an epinephrine that we use, a bronchodilator. That is epinephrine. That's a medication that can kind of do all of this. And again, if you're feverishly writing all this stuff down, you can kind of pump brakes a little bit. Again, this is just kind of some examples of some of the different medications that are out there. So again, the beta agonist. This is specifically a beta 2 agonist. That would be what sparks the bronchial tree to open up. It basically reduces some of the swelling in there. And again, this is albuterol. This right here is albuterol, 100%. I talked about the corticosteroids. Again, it reduces the inflammation. This is the solumedrol. And again, I'm skipping through some of these. So moving into the cardiovascular system. So that was respiratory. So cardiovascular. There's different meds that do different things. We know that some of the big highlights. We want the heart to be able to basically beat faster, stronger, and more pliable. we want it to be more pliable. So under those three categories, these are some of the different, there's different medications that can kind of fix or affect those three things. So dysrhythmia. So let's say VTAC, ventricular tachycardia. That is a cardiac rhythm that we should have learned in EMT school. That's one of the two rhythms that an AED will recognize and require a shock for. There's also, instead of the shock, there's also medications that we can give that can kind of interrupt that ectopic foci. Which, by the way, when we'll get into cardiology, it'll go into that. But basically, the ectopic just means the top. So it's basically the top, and focus means a specific spot. So really, again, just kind of tune this out if your brain's full. This is basically just antidysrhythmic medications. It fixes irregularities in the heart. That's really what you got to know. Also, the Vaughan Williams classification. This should be somewhere in the textbook here. I would write that down. The book wants you to know that. I don't particularly find a whole lot of need in that, so I'm not going to go real deep into that. But what I will say very specifically, of the classes that we're going to end up talking about, and there's going to be a couple of them. There's going to be some similarities between them, and that's not it. So write that term down, highlight that term, the Vaughan Williams classification. And if we get back to it, we get back to it. Otherwise, that's something you guys will be able to kind of go through and read on your. It's a very self-explanatory classification system. But I want to try to get to this stuff first. And I'm going to skip this because we're going to do all this in cardiology. Antidysrhythmics. So what we're looking at here. So the only takeaway for cardiovascular system. So for these specific antidysrhythmics. So again, we know that the beta 1 sites are what we're targeting for the heart because there's one heart. In real life, the couple things that we have problems with. We have bradycardia. So somebody's heart's not beating fast enough. So we have to give them a medication to speed it. They're hypotensive. So their heart's not beating strong enough. So again, there's a medication or some medications that we can give to force that heart to contract harder. There's some blocks where the atrium of the heart will beat, but the bottom of the heart or the ventricles don't receive the signal because there's some kind of delay or some block in there. So we can treat that with some of these channel blockers. So again, those are practical reasons that we would give that. The big thing for you guys to kind of take home on that is in the world of medicine, when people are discharged and they're discharged with a beta blocker. So beta 1, it's a beta 1 blocker. Well, we know that beta 1 is the heart, and a blocker would block the heart rate. So that beta blocker is literally keeping the actual pulse down. So for us, if you see those, and those typically end in LOL, so medications that end in the last 3 letters are LOL, typically that's a beta blocker. So those patients, we're going to look at them. They're going to be, if they're shocky or if they look relatively unwell, you can kind of consider that a lot of these elderly people are probably on a beta blocker. So their pulses are probably down in like the 50s and 60s. So when the body's trying to compensate for whatever problem's going on, it can't compensate because there's a blocking agent that's in the body affecting the beta 1 sites, and it's antagonizing it. It won't allow that heart rate to rise to try to compensate. So this can kind of create a pretty devastating pattern for us because again, they just can't fix themselves. They can't bring their own heart rate up to be able to compensate. So that's kind of what this is here. So beta blocker, again, metoprolol is the big one that you're going to see. There's some other ones in here for the antidysrhythmics, like amiodarone. That's a really big one that we're going to use. That's that one that I said can stay in the body for like 45 days or so. That's a pretty common one for us. And then there's calcium channel blockers. There's ACE inhibitors. There's a whole bunch of other ones. So again, if I said there's an alpha inhibitor, it basically is a medication that would basically inhibit the alpha sites. So if my blood pressure is really high, it's because my vascular system is constricted and it has a very, very high pressure in there. If I give an alpha, if I give some type of ACE inhibitor or some kind of alpha blocker, it's going to let that release. It's going to allow that pressure to kind of lower. So my blood pressure would end up coming down because my vascular system is going to dilate a little bit. So I'm going to skip through some of these because a lot of these are in the book. So with the medications, I don't want to sit here and just rot everybody's brains on a bunch of medication examples. There are some highlights here, but you guys are going to see that here in just a few minutes on your own. Dopamine is one of those that deals very specifically with the inotropic side. This forces that contractility to be stronger. So dopamine's a medication we give for that. And this goes on and on and on and on. Diuretics. And again, I just want to hit some of the big classes at this point because I think we're all pretty much about done with this. All right. So diuretics, again, the only one that we use is Lasix. We're starting to not use Lasix now in the field because in a lot of cases, by the time they get a therapeutic effect from the Lasix or that pharmacokinetics, the actual desired effects, it's later on. So it's not necessarily something that we typically want to do anymore. The other big problem with a diuretic is we're forcing them to excrete fluid. So if we're excreting fluid, they can very, very quickly become dehydrated. So when they're dehydrated, they end up hypotensive, and now they've got a cardiovascular problem on top of what we've got here. So that's something that we try to kind of stay away from. But the big common one is furosemide or Lasix. And again, they put a lot of disclaimers in here because it can cause some hemodynamic instability. Because again, you're ridding their body of fluid. So it's super, super easy to dehydrate these patients. So antihypertensives. So basically what they're deciding is if I can rid the body of extra fluid, I can block the heart from beating super fast, and I can dilate the blood, the actual vascular system. All three of those things in conjunction will absolutely fix somebody with high blood pressure. So that's where the medications end up getting used. There's a chart in the book that actually goes even deeper into that. And I'm going to probably, let's halt right there for just a minute. All right, so here's what we're going to do. We're going to do something a little different. Take a couple minutes. When you come back, you're going to be in a group. So give me just a second here and I'll tell you what group you're going to be in. All right. So when you hear your name, just write down what room I say for you. And then I'll tell you what you're going to do. So Savannah and Thomas, you will be room 1, and that's Versed. Richard and Ryan, so Benny and Waddell, you'll be in number 2. Your drug is albuterol. Segredo and Robert, you're going to be in room 3. That's Solumedrol. Spears, Camburn, you're going to be in 4, and that's epinephrine. Patrick Swearinger, you'll be in room 5, that's fentanyl. Bruno and Dowell, you'll be in 6, and that's metoprolol. Beckmeyer and Howell, you'll be in 7, and that's adenosine. And Helmuth and Merrill, you will be in room 8 with diphenhydramine. So what I need you guys to do, I'm gonna go ahead and break you guys out probably for maybe 15 or 20 minutes. While you're together, use whatever internet or whatever between the two of you. When you come back, I'm gonna need, for the medication that you have, I need to know what the 2 names are. So I need a generic name and I need a brand name of that particular medication. What is the drug classification So the class of your particular medication. What's the mechanism of action? Indications, contraindications, and dose. And just make it a generic adult dose. So take a few minutes. Like I said, I'm gonna break you guys out if you gotta use this time to bathroom break or whatever you gotta do. But when you get back, just have all that written down, and then you guys are gonna have to present that to the class for your particular medication. The reason I picked these is because these are the common ones that we're gonna see on a regular basis. So I'm gonna go ahead and break you guys out. And again, this is not going to be led by me. You guys will be in a room kind of by yourself, just the two of you. So do your thing. Come up with a spokesperson and how you're going to present that particular list. Spoiler alert: the back of the book has all of that information in it, so you should be able to use that. I just want you guys to kind of get in the habit of being able to look that stuff up. So we'll do this for, I don't know. We'll call it 20 minutes. Any questions before we do that? No. All right.
None.
See you guys in a few.